Hello, my name is John Cavetto, and this is Jen Carno. Our presentation is on prone positioning for mechanically ventilated patients. So the clinical problem is basically, first we got to define what ARDS is. And ARDS is an illness that is threatened or real respiratory failure, which damages epithelial barriers, causes pulmonary edema, and vascular permeability in the lungs. It is also known as acute respiratory distress syndrome. And also, we should define what prone positioning is also. Prone positioning is turning the patient on their stomach. It's basically repositioning to help with oxygenation. It's used to manage ARDS. Most studies focused on intubated patients. Not many studies are done yet on the effectiveness of prone positioning over supine positioning for mechanically ventilated patients. And our research question was, in adults who are mechanically ventilated, does prone positioning lead to better outcomes than supine positioning? Background and significance. In real life, prone positioning requires more staffing, more resources, including nursing and patient care techs to get involved. These sorts of things cost a lot of money, and so therefore it should only be used if it is found to be an efficacious intervention. Otherwise, we would be wasting resources on something that does not work. Some complications of prone positioning could be facial pressure sores, and most of the time it can be resolved by frequent turns and checking for injuries of sores, including signs of developing sores like redness. Current requirements for prone positioning with ARDS patients in general is about 16 hours per day while being in prone positioning. Because there is a risk for injury and because implementation requires so many resources, the need for investigating the effectiveness of prone positioning is paramount.
Okay, so I'm going to get into methods. And I want to first say that I used 4 search engines, which you can see in this table here. And by far, CINAHL by EBSCO, which we accessed through the Marquette Library, was the most high yield for the articles that we actually wound up using in our study. As you can see, there were thousands of articles found. It would have taken a very long time to look at all of them, but we outlined some specific inclusion and exclusion criteria. We wound up reviewing 9 of them for our research. Inclusion criteria included the use of systematic reviews, preferentially, focus on prone positioning over supine positioning, articles that were less than 5 years old, and focus on mechanically ventilated patients. Exclusion criteria, the articles were eliminated if they were older than 5 years, if they solely focused on intubated patients, and if the general focus was on ARDS rather than on mechanical ventilation with prone positioning. And this actually eliminated quite a few articles. Initially, 39 articles were read, but a lot of them did solely focus on intubated patients or just generally on ARDS as a result of COVID. And so actually, there was not as much research on the use of prone positioning for mechanically ventilated patients as we initially thought that there would be. This is our evidence table. It is quite difficult to impossible to see. We realized that there was a lot of information here, hard to put on a PowerPoint slide. But the results here were mixed results to some extent. Overall, prone positioning was associated with better outcomes and lower mortality rates for people who were mechanically ventilated, specifically lowering mortality rates for 28 days and 90 days. However, prone positioning was also associated with longer ICU stays and hospitalizations by as much as 2 weeks. Interventions seemed to work the best if a medical team created a team specific to prone positioning, which included techs responsible for turning and monitoring patients, wound care nurses specific for monitoring the pressure sores or pressure sore injury risk, and teams were looking out for a complication of moving tubing, even endotracheal tubing as patients returned, which is another common complication of prone positioning. There were additional interventions that were required to prevent the pressure sores on the face, as the pressure injuries on the face were by far the most common complication of prone positioning. The evidence showed that prone positioning does improve the oxygenation of patients with moderate to severe ARDS. Prone positioning might be associated with less time being intubated and shorter intubation periods. It may also mitigate the risks of the severity of illness, such as complication of ARDS. Prone positioning was found to be most effective with moderate to severe ARDS, and it was best for avoiding hypoxemia. The recommended usage for prone positioning is prolonged, which is 16 hours per day, and that's what improves oxygenation, but that's also what can cause pressure sores. There were some discrepancies in our findings with these mixed results, and I thought that perhaps we should talk about how COVID may have impacted the results. We did look at articles over the past 5 years, but COVID has been taking over for the past 2 years. So a lot of the research actually did focus on COVID, which put hospitals in a time where they were pressed for resources and in extenuating circumstances. And this really could have influenced our study and the results that we came up with. Overall, we concluded that more research is needed that will be specific to mechanically ventilated patients and the use of prone positioning.
Clinical recommendations. Basically, ICUs will need to have a protocol specific to addressing risks for injuries and pressure sores. Some methods of prevention would be prophylactic dressings, lubrication of the eyes, and the use of tape to secure the endotracheal tubes. ICU-specific teams that specialize in wound care and addressing risks would be a preferable item to have in this clinic for anyone. ICU team would be providing staffing needed to turn patients as well, as we do know that there is a need to turn these patients frequently in order to prevent injuries. Future research is needed outside of the context of COVID-19 because most of these studies that we did look at were in the context of COVID-19, and therefore there may be differences in data outside of the bounds of that. Future research should also provide quality RCTs on the use of prone positioning for patients who are mechanically ventilated as well.
All right, thank you for listening to our presentation.
Thank you.